Welcome, everyone. I'm Dr. John Martin, the Chief Medical Officer of Butterfly Network. We thank you for taking the time during this incredible moment in history to come together to both learn and, more importantly, share information. This COVID-19 pandemic is challenging us to be at our very best, to think in ways that we've never thought before, and execute at a scale that candidly none of us have any experience with in the past. There are many in this call that have felt the wrath of this virus before us. We must not miss the opportunity to learn from their experience. It is the only way forward. I also want to explain at this time why we're doing this at Butterfly. We believe passionately in the role of point-of-care ultrasound and the importance of democratizing imaging. Never in history before has this ever been more important. We are uni-focused on the education and information sharing that we're doing here tonight to advance the knowledge gained by those who have expertise in this area and for those around the world who are equally committed to making a difference. And so now we go forward this evening and we'll share information together and hopefully make all of us better and better equipped actually to deal with this dilemma. I'd like to start first by introducing the panelists that will be working with us tonight. We have Dr. Tung Chen, who's actually one of the most inspirational humans on the planet today. He's really brought to life the importance of both COVID and how it personally affects those of us in healthcare. He is the gentleman, the physician who is sitting at home scanning himself and has become the gentleman spreading the word across the world. So we're very appreciative. He's suffering from this terrible virus, but sharing his information has been a warrior for all of us. We also have with us Dr. Mike Stone, emergency physician, and head of education for Butterfly. He is an education expert and a point-of-care ultrasound expert and has been training physicians around the country and around the world for the better part of 2 decades. And finally, Rick Mendez, who is our head of clinical operations here at Butterfly. He's a renowned ultrasonographer and educator as well, and he's working with us tonight to help share this information. Let me start with the big why. The reason we are here tonight is because I think it's pretty evident from what we have learned from experts all around the country and all around the world that not everyone is an expert on lung ultrasound. And if you take any lesson away from what's been learned, both in China at first and now in Italy, and certainly what Dr. Chen is explaining us from Spain, point of care ultrasound is going to play a critical role. And so I think it's important that we spend the time tonight to try to bring everyone up to speed around the world where we can on the use of ultrasound, the techniques that are there, the specifics around, if you will, COVID infections in the lung, and the lessons that are learned. So this is why we're doing this tonight. We believe it plays a critical role. Now let's move on now and look at the map. And I think it's pretty easy to see from this, and those of you that don't follow this, this is the global cases monitored by the Johns Hopkins map. You can follow this every single day. It's incredibly useful to watch the dynamics as this has spread around the globe. A little scary to look at from all of us. I'm a little afraid that actually my children have found this map because it's also scaring them. But I think it brings to the reality that this problem is being felt by everyone. And I think the other important part for us is it shows us where these areas are hard hit first in advance of us. And we lean on the expertise and the experiences of those in those areas to help guide us to make decisions. Remember, this is unprecedented. And so we have to learn from others so that we can advance this and get better and better in each new outbreak in different areas of the United States. So this is at a Johns Hopkins website. You should look for this and follow it for your area. Well, let's start with an historical perspective on lung ultrasound. Listen, the COVID-19 thing is not the first time anyone thought about using ultrasound for the lung. And to do that, I'll turn to Mike, who's had much more experience for decades than I on lung ultrasound. Mike, you want to take it from here?
Sure, thanks, John. So I think important for us to realize that we're here to talk about the utility of point of care ultrasound and particularly lung ultrasound. We'll be talking about some specifics around how to do the exam and what images will look like a little bit later, but just to take some perspective, lung ultrasound for the diagnosis of pulmonary conditions and pathology has been around since the late 1990s, really. So we're looking at 30 years of experience with using ultrasound to look at the lung, and yet it's still really unfamiliar to a lot of providers because the traditional radiology approach to lung imaging has relied largely on chest radiography and computed tomography or CT scanning. So lots of point of care providers, whether emergency medicine, pre-hospital, intensivists are used to looking at the lung with ultrasound and kind of know what they can use it for. And the big things that we've looked for historically with lung ultrasound have been pneumothorax, pulmonary edema, pneumonia, pleural effusions, pulmonary contusion and trauma, ARDS. So there's a wide breadth of what you can look at with ultrasound when you're examining the lungs. And these are just some of the literally hundreds of papers looking at lung ultrasound for different pulmonary pathology. Lessons learned from China and Italy. Most of the experience that we've seen from frontline providers with point of care ultrasound around lung imaging has come from China and Italy, just because of the temporal nature of the spread of COVID-19. And obviously we're learning from providers in other countries like Tung Chen in Spain and like many of our colleagues here in the States. But most of the information that we've taken away at this point and tried to assimilate to come up with some guidance around how lung ultrasound could potentially be beneficial in these patients has come from a number of intensivist, emergency physician, and frontline providers in both China and Italy. And we cannot thank them enough for sharing their experience, because it's given us a bit of a head start in preparing. Not a lot of evidence on lung ultrasound in COVID-19, and we should just say that up front. This is a disease process that's really been around for 6 months or less, and has hard hit so many parts of the world that there hasn't really been a lot of time for people to design a lot of prospective randomized trials on different imaging and diagnostic techniques, or on different therapeutic techniques thus far. So, one of the things with responding to a crisis in real time and trying to get guidance out for clinicians and frontline providers is that, by definition, some of the things that we're going to talk about and potentially propose or suggest may look foolish in 3 or 4 months when we know more. And I think it's worth knowing that there are publications already arising about findings of lung ultrasound in SARS-CoV-2 or COVID-19 infected patients, and the fact that it correlates tremendously well to CT imaging and chest radiography. And from many parts of the world, we've heard that the resource utilization involved in getting chest radiographs or in transporting patients back and forth to CT scanning with concerns for co-infection or spread of the virus while moving patients around the hospital have been limiting factors. And you can rest assured that there are many places currently using lung ultrasound as a primary imaging modality to try and address some of these concerns.
Yeah, Mike, I think it's important to note, and we hear this a lot, academic centers typically, and many of us like to see really definitive data to back up some of the recommendations we're trying to make here. But I think the reality is this is just unusual times, and we have to actually move quickly, and we don't have the luxury of long-term studies to validate this stuff. So we have to trust the experience of those from around the world, use a little bit of our clinical judgment, and leverage the lessons learned and apply them more quickly than we may historically do.
Using some examples from some of our colleagues, we can just review quickly what some of the ultrasound features look like. But before we do so, I think there's a couple of things worth mentioning. Number one, there are lots of conditions that can cause B-lines, and we'll talk about B-lines in a moment. B-lines can happen in pulmonary edema from volume overload in a patient with renal failure. They can happen in decompensated heart failure. They can happen in inhalational injury or lung trauma from a pulmonary contusion. There are some features that we're seeing emerging in patterns in some of these COVID-19 patients with significant lung findings that may help differentiate those things. But one thing for providers who are thinking about using lung ultrasound as a screening modality is that lots of patients will have B-lines. They can come from lots of different conditions. And in addition, patients with SARS-CoV-2 or COVID-19 may have B-lines, but that doesn't necessarily mean that they're particularly ill at that moment and need hospitalization. And I think it's important to throw out as a caveat that right now, On this slide, in this segment, we're just talking about some of the lung findings. We're going to talk about some potential ways that providers could try and take the available evidence and the available anecdotal experience and try and assimilate that into some pathways where they could benefit their patients in terms of either triage or monitoring for recovery or monitoring for the effects of therapeutic interventions. But right now we're just looking at what lung looks like. And I want to make that caveat. So we can go ahead, we can play that left slide. This is a normal lung and we're in a lung preset. There's a rib and a shadow, a rib and a shadow. That's the pleural line. It's bright or hyperechoic horizontal line just deep to the ribs, nice and smooth in this case. It's sliding left and right on the screen, indicating that there's no pneumothorax at this location. And that's an A line. That's an A line. That's another one. Those are just horizontal reverberation artifacts from an air-filled lung. And that's a normal looking lung. If we look at the adjacent clip, this is a patient with PCR proven SARS-CoV-2 and COVID-19, lung preset again, rib and shadow, rib over there, and pleural line. And we can see that there's some focal B lines just under the rib and in the leftmost interspace, but an area of spared normal A lines on the right side of those B lines. And these sort of skip areas and patchy B lines and confluent B lines, that's a pattern that we are seeing commonly in many of the images that have been sent to us over the last several weeks. Why don't we take a look at the 1 second to the right? I think we can skip that middle one for the moment. And here, just even a clearer example. So again, lung preset, rib and shadow, and then adjacent rib and shadow. And you can see that the pleural line is thickened right there, that there's a small amount of subpleural consolidation on the right there, right where the arrow is, and that you've got some intervening segment of pleura that isn't demonstrating B lines. So thickened pleura, sort of discontinuity of the pleural line, and then this B line pattern with areas of spared lung. That's another pretty typical feature that is popping up. And then I think lastly, we can take a look at that clip on the right. And this is much more of a traditional consolidation. And we're going to be in a lung preset doing the same imaging technique, finding the ribs and shadows. And you've got an area of really almost solid organ appearing tissue under the pleural line there. You've got some small air bronchograms. This isn't dissimilar from what you might see in a bacterial pneumonia, but these are some of the additional findings that we're seeing.
Hey, Mike, this is Rick. I have a question from the audience. So how would you use these ultrasound findings when triaging patients and making your determination to admit them or to then send them home in self-isolation and monitor?
Yeah, so that's a fantastic question. And the first thing that I want to be extraordinarily clear about is that you should not be making admission and discharge decisions based solely on a lung ultrasound. We're looking at patients clinically. Clinical judgment is supreme here, and probably the single most important factor is what does a patient's work of breathing look like and what is their oxygen requirement. So if you have a patient with clear lungs on lung ultrasound, no significant oxygen requirement, to me, that's a patient who could be screened and sent away from the healthcare system to self-isolate. On the other hand, somebody with no oxygen requirement and no significant increased work of breathing who looks well, but has a bunch of pulmonary findings, whether it's scattered B lines or even some small subpleural consolidations. My own personal practice in this case is to discharge and self-isolate, but to work to arrange some outpatient follow-up and some really strict return precautions, because those patients we're seeing can progress pretty rapidly, or they can progress over 6 to 8 days. So you know that they're having lung findings, but they look well. To me, it's just a higher risk population, but I wouldn't be bringing that patient into the hospital if they don't need oxygen and they appear well, because you're going to be using vital resources for patients who need it more urgently. And admission decisions are going to be based on patients who are tremendously ill. So people with hypoxia, increased work of breathing, who look unwell, those patients are going to be coming in kind of regardless of what their lung ultrasound shows. But I would say that lung ultrasound in those patients, since we're trying to limit chest X-ray and CT imaging, may still be quite useful, because we have to remember that despite, and we're learning these lessons from all of our frontline providers around the world, that despite the COVID-19 pandemic, people still develop acute decompensated heart failure, and they still develop pleural effusions from their heart failure or their lung malignancies, and they still have COPD exacerbations. And being able to address the underlying cause in some of these patients, you can do quite well with lung ultrasound, and that's leaning on the literature that we've had for almost 30 years at this point. And this is, you know, there's a big caveat there on the left, right? This is based on expert suggestion, and I want to be clear, this is not my expert suggestion. This is polling all of the lung ultrasound experts that I know.
I think it's the Stone algorithm.
It is not the Stone algorithm. And I think that realistically, this is going to be changing as we get more information back and as this pandemic progresses. So this is by no means, you know, a final pathway. This is by no means, you know, evidence-based at this point. One of the issues that I've heard, and I should say it's really going to be regionalized. So, you know, I have a close colleague in Italy who's really on the front lines and, you know, working 12-hour shifts most of the week and just doing this day in and day out. They have a several-hour turnaround for a SARS-CoV-2 PCR. So they can test patients and get a result back in 3 to 4 hours. They're still using lung ultrasound in their triage assessments, but in my hospital and in most of the hospitals in the US right now, either you really can't get access to testing, but even if you can, you know, I've cared for patients where 4 days later, their PCR test is still pending. So, you know, I'm not able to make dispo and management decisions based on a PCR result. So I have heard from some places in the world, you know, rapid PCR positive, hypoxic, they're admitted and you're putting them into a COVID unit. And that seems very reasonable. And, you know, imaging can be at the discretion of the treating provider. In my own personal practice and in many of my US colleagues' practices, there's no testing that's immediately available. So lung ultrasound may be a nice screening modality, although we don't know, not prospectively studied. So I'm not going to run through each one of these. This is available online on the Butterfly site. We kind of talked about how you might implement some of these findings into a triage pathway, but this is rapidly evolving. And I think if we're going to take a step and say, where is lung ultrasound really being proven to be indispensable in the care of sick COVID-19 patients, my experience hearing from colleagues has been in monitoring for progression of disease. So for seeing resumption of A lines as patients start to improve, and then sometimes recurrence of B lines or subpleural consolidation as the disease waxes and wanes, and just following the lung course. The other has been in recruitment maneuvers. So in patients who are on ventilators or on non-invasive positive pressure, who you're looking to see if you're able to aerate the lung and recruit more lung, that bedside ultrasound has really played a vital role there.
Yeah, Mike, and I want to pause here for a moment on this because I think, you know, this is an interesting scenario, and I think you're very cautious, and it's the academic mind in you of saying this is not proven and we've got further evidence, and you're being appropriately intellectually cautious. But I'll take the surgical bent. You know, I'm a surgeon, and we tend to be a little bit more bolder, and my medicine colleagues would suggest maybe not as thoughtful. But the problem is right now, if you wait for definitive proof for some of these things, in this current scenario, it's too late. It's too late. So I think we've learned enough from ultrasound that it can be helpful. And I think there is great value in really two key points that you've made. One of which is not everybody with an ugly looking ultrasound necessarily needs to be admitted. And we have to learn and try to refine that. A lot really depends on how well you can follow those patients once they're discharged. If you've got somebody you're going to send home where you don't think you can reliably get in contact with them and they've got an ugly x-ray, the surgeon in me says we might need to be more cautious in those, obviously depending on how much resources. Somebody's really reliable, you let them go. The flip side of that is what we've also learned is that necessarily the clinical symptoms, like hypoxia, tachycardia, dyspnea, may lag behind what we've seen actually on the ultrasound. And so we have to balance both of those things. And so while we're waiting for definitive information to really iron these down and maybe put them in stone, I think for now, you like that?
That was horrible. That was a dad joke.
Before we put them in stone, we have to remember both. And I think we're dependent upon all of us to use good clinical judgment. The flip side of that is part of what we want to do and use through what we've done here at Butterfly, share information and knowledge. So that if you've learned it, like Dr. Chen has taught us a lot over there about monitoring his own condition and seeing B-lines in his stuff, and he's pretty comfortable at home. That's not appearing in a paper right now. And so we've got to find different ways to communicate that information so that we can all share.
Well, and I think it's really important that we focus on a couple of additional things. One, we make those decisions all the time. So if I'm taking care of a homeless patient with substance abuse issues who has a bad leg infection, that might be an infection that in a well-appearing, reliable patient, I could put on some oral antibiotics and discharge. But in those patients I may need to admit. So again, if you see someone where follow-up is an issue and you're seeing very concerning lung findings, you're going to have to weigh that and make a clinical decision about it. And I don't think we can put a flow diagram out there that's going to catch every single type of situation like this. Medicine is not a flow diagram. The other thing is, we really welcome any information about people's experiences. We have a link on the page to submit information and to get in touch with us. And at this point, I can speak for myself. My primary goal is to get people aware of the potential utility of lung ultrasound and to learn from everybody who's out there doing it. And I don't personally care if you're scanning with it doesn't matter what device you're scanning with, send us your images. We want to work on trying to get a sense of what's happening and what these patterns look like. And we really just want to encourage a global community that's sharing information and getting smarter together so we can help our patients.
Mike has been very kind enough to put a demonstration together here to look at the technique, because not everybody's familiar with how to do lung ultrasound.
Indicator up towards the head, and you're really just sliding up and down the chest until you find an interspace between two ribs, which is right there. You can adjust your depth a bit to make sure you're seeing A-lines, adjust your gain to get a nice crisp image. And there's a few different maneuvers here. You want to fan left and right to really bring the pleural line as high up on the screen as possible, so it's low there. And now as we slowly fan, we bring it up. And when it's as high on the screen as you can get it, that's when you're going to be perpendicular to it and see those A-lines. We have a whole suite of ultrasound videos around lung ultrasound, image acquisition and interpretation. And one of the first things we did when we started seeing word of lung ultrasound being used in COVID is we unlocked that for anyone, whether you have a Butterfly subscription or not. So you're able to link to that from the page. There's a bunch of free video content on there showing you how to do a lung ultrasound. If you're ultrasounding with a device that's not a Butterfly, it's typically a curvilinear or a linear probe. Some people like using a sector probe. So really whatever you have, you should be able to get some good useful information with lung ultrasound imaging. But feel free to take a look at some of those free videos and hopefully it'll help you with some of your technique.
Yeah, and don't hesitate to give us some feedback. I think that would all be helpful as we actually increase the number of these things that can be educational. I think we want to pause for a moment here and actually get from word out on the street. I think we are blessed actually this evening and honored to have Dr. Chen with us, who can share with him his personal experience. It's hard to imagine someone live broadcasting their illness. It's a new thing for me, and I know a new thing for Dr. Chen. But Dr. Chen, how are you doing this evening?
Thank you, John. Very good, and really, really thankful to be invited to this webinar with the real experts.
Well, I think many may not know your story, but I think why don't you start from the beginning and say, first of all, how did you get it? How did you recognize it? And what have you experienced? And has it been significantly different from those that we've seen in the reports? And then let's talk about what you've actually done that's so unique from everyone else in the world at the moment.
Thank you, John. Sure. All started a couple of weeks ago when we were getting ready for this pandemic in my hospital. I work in a tertiary academic hospital where we treat most of the suspicions of coronavirus patients. And then we started to train how to put the equipment, how to take it off, and do the CRP of the test of these patients. And then the thing is that from 1 week to the other, in just a couple of days, we move from everyone's suspicions of having COVID and the test turning to be negative, we moved to many positives. And right at that moment, I was working in the front line in the COVID section that we had. And what struck me most was that many of these patients were mildly symptomatic. They were young people who only had something which we could define a little bit worse than a common cold. And many of those patients came. We did the CRP because of the epidemiological factors, criteria that they had with close contacts or travels. And then several hours later, we had the result that most of them, they were positive. And then that evening, I started to feel chills. I started to feel a dry cough, some myalgias and asthenia. So at that moment, I did the CRP, and they told me that it turned to be positive. And because of my positive, many of my friends and colleagues around me, they did the test as well. And one of them, who was symptomatic long time before me, he was probably the source of the right now 12 infections we have in my ED.
So let me ask you a question. Have you lost friends because of this, or are you still friends with the guy that started it?
No, that's the lesson learned right now, that be careful with anyone, be suspicious with anyone around you who is coughing, even if it's the ultrasound fellow of that month.
One other thing, and I want to pause here before we keep going, because there's a point that you made that I think Mike and I were talking about this early today. There's a lot of thought around, okay, if someone comes in with respiratory symptoms, we'll put them over into a box over here. We're worried about them. But we're forgetting about the fact that there's a whole lot of people that were probably exposed that are coming into the emergency room with something else. And if we don't take those precautions, we get in trouble. Mike, you want to share the story you shared with me earlier today?
Yeah, when we've had multiple, there was a webinar with the American College of Emergency Physicians yesterday where multiple people shared stories of exposure to patients who were in the emergency department for seemingly completely unrelated issues, whether trauma or general medicine issues, but zero complaints of fever, zero complaints of cough, no shortness of breath, no chest tightness, not even some of the more unusual or uncommon complaints around, nausea, vomiting, diarrhea, but really nothing that anyone would attribute to a coronavirus infection. And ultimately, those patients were exposed, were ultimately tested as they developed additional symptoms later in their course, and were positive, but were asymptomatic from an infectious standpoint when they showed up.
So I think it underscores it's a whole different world now. This is a situation where you're guilty until proven otherwise. If you're showing up into the emergency room. So Dr.
Actually, I had the most recent anecdote that happened to me this morning. That it was I had my wife and my 2 kids isolated with some relatives because they tested negative around 10 days ago. And yesterday, my wife started to complain about some throat soreness, throat ache. And the thing is that we are getting to spring. She has some allergies. She didn't mind at all about her symptoms. What did I do yesterday? I went right away to pick her up and come back home. And at that moment, I phoned the health public services to come to my house to do the test. But since we are running low on tests and now you have to carefully screen which patients you are gonna do the test, they just answer me that it was not possible to do the test. So I have to treat her like if she had an undetermined result. What did I do at that moment? Well, you can imagine. So I have a disease that even in mild patient, asymptomatic patients, gives you a long picture. So what I did was to scan her back, and were the B lines with the thickened pleura, and I didn't need to do anything else. That was the positive result I was waiting for.
Wow.
So you shared kindly with your wife, is what you're telling us today.
Actually, I put her on hydroxychloroquine, and I told her, honey, we have to share everything.
So, so it's a great story. And unfortunately, I think this is probably going to be something that happens most commonly. And I think it underscores a couple of things. We know family members of all of us in healthcare pay a big price for being married or obviously with people in healthcare, because our healthcare and our patients come first. And this is another example where it's even worse. And so I think all of us feel this bond with the risks that everyone is taking out on the front line. We decided that when we became healthcare workers. Unfortunately, our family's facing the same thing. So our best wishes with your wife. We look forward to hearing your progress. But let's go to the point where you decided, okay, I'm home. I have a unique both expertise as well as opportunity in your hand. And tell us what you did next and where you've come with that.
I didn't do anything special. That's one thing I want to remark. Any POCUS enthusiast, the first thing she does is to share our experience or patients' experiences on Twitter, on social media. Why? Because that's the way we learn, and we can get into touch from one point of the world to the other point of the world. So it was, for me, the most reasonable answer to this lack of COVID-19 lung ultrasound evidence was to share my own lungs. So what I did was to scan, see everything was normal, but is really normal, or is because I got the scan too early? So I had to share what was gonna to happen along with my evolution, because as we know from the Chinese experience, we know that most of these patients of us, we got abnormalities on CT scan, but we all know that CT, it's impossible, it's unavoidable to have it, all our patients to go through that. And even if we had that resource, you wouldn't even think of having mild patients going through the CT. So I just
did you
needed
see an evolution in your ultrasound? How many days out are you now?
11.
11 days out. And did you see an evolution of your findings over this period of time?
Yes. As my symptoms started, the main place where to look the findings are on the back lower lobes. So on the plaps, what they call plaps. And so there, I found that I started by having a normal A pattern with A lines, normal lung sliding, and then started to appear bilaterally some thickening of the pleura and some B lines. As my disease progressed, the lower backs started to clear, but then I started to find some other spots to be affected, especially on the lateral sides, on my axillary fossa, subscapulary fossa. So those are other places where to look. And my wife, actually, she had also on the lateral aspect. And other cohabitants in my house She has also on the lower back, but also on the lateral aspect. None of us, and from the cases I review from my hospital and other colleagues of mine isolated at home, I haven't seen that in the anterior aspect, none of us we had it any abnormalities. So I would say that the most cost effective is to scan the back and the lateral aspects. And as Mike said before, this DC goes back and forth, and so were my lesions. I started to have on the backs, and then they started to clear up, and then a couple of days later reappear. It's something that is quite different from any other viral pneumonias that we have faced in the past, that many of the influenza or RSV infection, you have the whole picture at the beginning and then it starts to clear up. Here, you go back and forth, and so are my symptoms. With a little bit of delay, I start to experience more cough or more tiredness. So that's the main reasons why I changed the management of my disease, and with consensus with another colleague from infectious disease, I started on my day 4th when the subpleural consolidations appeared for the first time. I started on hydroxychloroquine, and then today that I started to get again the subpleural consolidations bilaterally and more with more affected areas, I started with azithromycin. So those are the things where ultrasound can be a guidance for the therapy, not only monitoring that everything goes well, because my oxygen saturation never dropped below 95. I'm been always above that and without any dyspnea, shortness of breath, chest pain.
Yeah, so I think, you bring upon an interesting point, and part of what we have to learn along the way is what is unique about this. And I think some of the findings, again, you've noticed, and we've seen that consistently in the literature with CT as well, is posterior lateral is typically where things are, more commonly bilateral than what we've seen in the past, and certainly B lines and thickening and some patchy consolidation. On CT, they talk about it being ground glass. I think what's not been talked around a lot is the treatment, and we'll try to cover that in the future in an upcoming one. What have we actually done with patients when they've gotten in the hospital? What medications are being used? Let's talk a little bit about the management in the future, about how we ventilate these people and how can ultrasound be helpful in that regard, because I think that's important. There's also some, hint of some cardiac stuff that we also have to get much more data on before I think we can all be comfortable talking about it. But I think those are things that we can address in the future. But we're really grateful for what you've done and sharing your story, because I think it's evident, first of all, it's important. The things that you have shared with us are incredibly important to tell the story. Second of which is you've identified something that I think that still needs to be further evaluated, and that is the value proposition of monitoring somebody at home with imaging. Historically, we talk a lot about telemedicine. There's great conversations about it here in the United States, but telemedicine, for the most part, is a teleconversation. And that's not to say that that's not helpful, but we certainly know, and you certainly have demonstrated this, that imaging can be tremendously helpful to upgrade the value proposition of isolating patients in environments that won't consolidate everybody in the hospital. So stick with us to the end, because I'm sure there's going to be questions for you, but I want to be very grateful, express the gratitude of all of us for what you've shared with the world.
No. Thank you, John.
Jolly, can I ask you? Can we go back for 1 second on the slide? I just wanted to ask you, as a self-confessed ultrasound nerd, one of the things that we're hearing is that pleural effusions are uncommon in this disease process, and the kind of pleural effusion that we're seeing in that middle clip is definitely the kind that you would not see on a chest X-ray, and you might not even appreciate on a CT. We know that ultrasound is, tremendously sensitive, maybe overly sensitive for pleural effusion. Did those get much bigger, or that was about as much as you saw in terms of your pleural fluid?
Yes, definitely. And That's why I feel pretty confident with some of the protocols releasing in the different hospitals. They are proposing to do X-rays to detect this disease. So it was pretty easy to think, if you can do X-ray and that is a valid method, why not changing that into something which is even more powerful to detect interstitial disease and to detect even pleural effusion, which is known to be a risk factor of bad prognosis. So yeah, definitely I had it on my second, third day, but then rapidly disappeared. So
Okay.
right now, I don't know what's the meaning of that, but as my lungs got worse, they disappear.
Okay.
What, Rick, do you got some questions you want to share with us here? And we'll see with between the two experts here, we can kick around some answers that might be helpful for people.
Absolutely, John. Thank you. So this first one goes out to Dr. Chen. Have you performed cardiac imaging? And have you noticed any findings that are consistent with the COVID?
I did. I didn't do it daily on a daily basis, but every 2 days I've scanned my heart as well, and I haven't found any big issues. Nothing remarkable.
We've got a lot to learn about this one, and we'll stay tuned. I think this is going to be a topic that we're following closely, and we'll have to share in a future one because I think it's out there and people are hearing about it and thinking about it, and so this will be something that we're certainly going to address. What do you have next, Rick?
Yeah, so this one I'll direct to Dr. Stone, and this one really revolves around the proper cleaning of any type of ultrasound device. Can you speak to that a little bit and maybe the decision that goes into determining whether or not to even utilize ultrasound in those cases with a known positive patient?
Yeah, I mean, I think that, just because you can ultrasound the lungs doesn't mean you should be doing it as frequently as possible all day long on patients with proven disease, right? We definitely want to use proper personal protective equipment, and we need to unfortunately think about rationing that equipment these days in terms of availability and shortages. In terms of disinfecting solutions, most solutions with a high enough concentration of bleach or ethanol or any of the other common disinfecting solutions are adequate, it seems, but there's not a lot of prospective data here. You can look at the CDC for guidelines. We've got a link to some of the evidence base that's emerging around disinfecting protocols. I think if you feel that it's going to change your management in a patient and that you're going to get useful information out of a lung ultrasound or out of a CT or out of a chest x-ray. If you're transporting that patient for a chest x-ray, you're exposing everyone along the way, the person doing the transport as well as the radiology technician. Same thing for CT. If you're doing an ultrasound, it's one provider going and taking a look with an ultrasound. So, I don't have particular concerns about nosocomial transmission or increased transmission to providers. Personally, I'd rather do an ultrasound with proper cleaning of the device and proper PPE than send that patient across the hospital to have someone else do the exact same thing and interrupt. I mean, it's not like a radiology technician isn't placing a plate behind the patient, or a CT technician isn't helping the patient lay down on the gurney. It's still, healthcare provider contact with the patient. And if you can minimize that and use proper disinfecting protocols, to me, that doesn't seem like an increased risk. But we're in very much a emerging area that we have no prospective data to support or deny that opinion.
Yeah, and I think the other part here, Mike, that's important, and you talk about this, and I've seen your images, is the beauty of the handheld devices that are out there today. They can fit in the sleeve, which helps tremendously. You can, if it's attached to a phone, you can put the phone and the device in the sleeve. And so that's one way actually to help in this process. And that's difficult to do with a cart. Obviously doable, but difficult to do with a cart.
Well, and the issue really revolves, and from what we're learning, it seems that the issue really revolves around whether you're having if we're going to talk about ultrasound, whether you're having an ultrasound device in the same room as a patient with an aerosol generating procedure being performed. So, if somebody's on high flow nasal cannula oxygen, or non-invasive positive pressure or being endotracheally intubated. The idea is that you've now generated aerosol and everything in that room is coated. If you're going to get a giant plastic drape to put over your traditional cart-based point of care ultrasound, and you've got a probe sheath on the probe and on the cable, that you're doing a good job, I think, protecting that device as best you can. If you have obviously if you have a handheld unit, whatever manufacturer, if it fits into a sleeve and the whole thing fits in and is self-contained, it just seems much more intuitively easier to clean than a giant system. But for regular probe contact with a patient, I think, covering the probe is a great idea. And at the same time, if we're running out of masks and we're running out of ventilators, it's hard to imagine that at some point we're not going to run out of sterile probe sheets. So, I think just good disinfecting protocols and doing the best that you can is probably what we're stuck with at the moment.
Yeah, one of the other things to this point, I want to keep moving. I don't want to belabor it, but it brings up a good one. And one of the things that we've seen is in the patients, and I've heard this from physicians hardest hit in Italy repeatedly, is that in the COVID wards, when they make rounds, they'll come in, they'll scan their lungs, they'll scan their heart, looking for the cardiac issues, and scan the IVC collapsibility to take care of all three of those assessments at one time with the single physician. So you're not looking at it at different times with different people. So I think the versatility of what we can get out of ultrasound can be incredibly helpful. Rick, what do you got for us next?
How do you handle those requests that come to you, Mike, on training and education and where they can get access to this material?
So there's a host of links already on the Butterfly COVID-19 response page, which is linked to from the main butterflynetwork.com page. And we're continuing to add educational information and resources there. What I would say, and there's also this great thing called Google, and there's a lot of people releasing free open access education around lung ultrasound, and I encourage that from anybody who's on the I don't have a participant list, but anybody who's on this call who's an educator, please put your stuff out there for free. You can always decide that you want to change that 6 months from now, but I think it's our responsibility to train people and to give them these tools. The good news is that lung ultrasound, as opposed to say echocardiography, lung ultrasound is really easily learned. This is not a complex scan. The lung surface is very accessible. There aren't these tiny windows to work with. And, in my experience, you can teach somebody how to do a lung ultrasound. If you're in person, you can teach them how to do it in 15, 20 minutes. It takes some practice, but I've taught teenagers how to do lung ultrasound as part of high school education. So this is an easy exam to learn. It's not like trying to get an apical 5-chamber view in an echocardiogram. I mean, this is pretty simply learned. So get online, look at examples, go to our site for some links to education, and lean on your local communities to see if there's people doing it who you might be able to learn from.
Terrific. I'll follow that up, Dr. Stone, with the prevalence of hand-carried devices. How accurate are those images compared to the more traditional or conventional ultrasound systems in the healthcare environment?
So I've used pretty much every handheld device that's out there at one time or another. And for lung imaging, I feel very confident that they compare as well, and in some cases better, to any of the other imaging devices that are out there. Lung imaging is this really interesting thing where kind of the more processed and smoothed and refined the image is, the harder it is to see the artifacts that we depend on to make diagnoses in lung ultrasound, like B lines and like A lines and subpleural consolidations. So some of these, $200,000 machines that are sitting in radiology won't get you any better of an answer than you can get with a handheld device. And that's not always the case when it comes to things like echocardiography or like liver ultrasound or fine soft tissue scanning. But from a lung perspective, I would happily scan with any handheld device and feel like I could make the diagnosis I needed to make with lung sonography.
Hey, Rick, I want to jump into one I saw from our good friend Peter, who Mike knows very well, which is a really interesting question. And I like those that take the contrary view. So Peter asked, it seems like POCUS for triage assessment with a normal O2 sat and no respiratory distress and screening for early findings, but not changing management, exposes equipment to unnecessarily maybe to disease. How would you answer your friend Peter with that, Mike?
I think that if somebody looks tremendously well and you're able to, and their oxygen sat is great, and you choose not to incorporate ultrasound into the like perfectly well, worried, well appearing patients who are coming in for triage, I think that we are not going to have the resources to scan every single one of those patients, just even provider time wise, not even with an infection control perspective. So I think that, again, we're trying to throw out some broad suggestions and get input from people. I'm definitely not telling anyone, especially Peter, how to practice medicine, because he's phenomenal and doesn't need any guidance from me. I would say that if there's, if I saw several patients in the last week who came in to the emergency department concerned that they might have coronavirus, and several of them were young, healthy, calm respiratory rates, no distress, clear lungs on auscultation, and also an oxygen saturation that was perfect. And I did not do an ultrasound on those patients. I said, you need to leave here right now because there's no reason to hospitalize you. I can't test you because you're not getting hospitalized, and that's our institutional policy right now. And we don't have a test to offer you. And you just need to use your judgment. I told them what to look out for, how to self-isolate. We have a nice, discharge instructions around, reducing the chance that you'll spread illness to others or contract it, and what social distancing really means, and just good education and follow-up. That said, if you're seeing somebody who has dyspnea, for me, that's my trigger. Even if their oxygen saturation is normal, if they're feeling short of breath, I do want to take a look at their lungs, and that's how I'm personally making that distinction right now. But this is a clinical judgment for providers and institutions to make on their own accord.
Actually, regarding that, we just had today in my hospital a new protocol release, and we are right now considering X-ray to any COVID-19 suspicious patient. The one healthy, without risk factors, below 60 years old, gets an X-ray and doesn't get a COVID-19 test. And that one, if the X-ray is normal, you send them home. So in this case, you rather prefer to having that patient waiting a couple of hours in the emergency department or do a quick scan. Probably it's more, the argument is more about doing X-ray, is it necessary or not? But since it's already in our protocol, I would rather prefer to do a more useful test that will give me more information than having that.
Yeah, I think, Gali, you bring up a really good point, and I think this is maybe my soapbox in all of this, and we're getting near the end, but I think if you've got clinicians and people trained in ultrasound, in my eyes, it's a better solution. I don't want to send my X-ray tech in there and put a plate in there and do those things. I don't want to do that. I think it's not a better answer. If we're going to send somebody in there that has experienced ultrasound them and answer the question. But the problem is not everybody can do that. And so part of the reason we're doing this, and my plea, and candidly, this is my plea up to senior health officials, particularly to those hospitals that are getting ready for the onslaught, look into ultrasound, make sure you've got equipment, try to get your people trained. And I think Mike expressed it best. This isn't weeks and weeks and weeks of training. You literally, Mike, how many hours do you think it takes to have someone at least reasonably capable of doing this, maybe with some references, sharing some images of saying that they can adequately do this, so this could be a tool they use?
So I'll hedge a little bit because it depends on the learner and their ability with sort of eye-hand coordination and any prior experience in ultrasound. But I have taught completely naive people how to look for lung sliding A lines and B lines successfully in less than 30, 40-minute session. So it's not challenging to learn. And, in my institution, our nursing staff place ultrasound guided IVs. They do bladder volume assessments. Many of them have approached me about learning to do ultrasound because they've seen some of the docs, including myself, doing ultrasound for lung. And they've, I've been amazed at just how quickly they pick up that skill. It is not a challenging thing to learn. The one other thing I just throw out as per the last question, and chest X-ray as a screen and waiting around versus ultrasound, as we're moving a lot of our triage processes out to outside of the hospital and to tents out front, X-ray, you're either having a patient wait around in a tent until they're able to be brought into the hospital to get an X-ray, as opposed to providing some imaging in the tent outside of the hospital and never getting that patient inside the hospital. So just another, there's multiple sides to this infection exposure risk consideration, and just one other thing to keep in mind.
All right, well, we'll stop here. We've gotten to the end of the hour, and you can send your questions in. You can see where you can email us and send that information to us. I want to thank, and we'll try our best to follow up with you with either our experts here or the others that are joining with us to share information from around the world. Mike, Yali, Rick, thank you all very much for sharing your experience, and thank all of you for participating. We will do more of these because we've got a lot more to learn. Candidly, there's a lot more we don't know than what we do know right now about this, but we're committed to share that with you. We thank you for the efforts that you're making to take care of the patients and the loved ones in your community. We wish you good luck. Please be safe. Use good methods. Share with us any information you have, anything you'd like to share with others, and we will pass that on. And Yali, best of wishes to your wife. We hope she does well, and we wish you all best. Thank you all very much for participating.